Pnawn da pawb, good afternoon. I'm really delighted to have been asked by Health and Care Research Wales to be here this afternoon to chair this final plenary session on recovery and learning, new ideas in healthcare delivery. I have a passing interest of this, of course, in my NHS Wales Chief Executive role, and I will also be taking some scrupulous notes during the course of the afternoon. Just to say that I hope you've enjoyed today's conference so far and managed to attend some of the interesting and very topical sessions that have allowed us to reflect on our experiences during the pandemic, but also to, importantly, hear about the direction of travel for the research agenda. And I wanted to say that it really is wonderful that many of you have been able to join this second digitally held Health and Care Research Wales conference. And I think the numbers that we've had joining us through the course of the day shows how important this event has become in the calendar for the health and social care research community in Wales, as we look back and we celebrate another challenging and busy year. And just to say that it will give me enormous pleasure following the session to present the Health and Care Research Wales Awards for 2021, which demonstrates the achievements of the research community in Wales over the past 12 months. And I'm really pleased that to some extent, despite the fact that this remains virtual, it's allowing ourselves to recognise that even with the pandemic context that we've gone through, just wanting to ensure that we are getting ourselves back into some more of a normal routine and rhythm. And hopefully there will be a time in the future, of course, when we can gather physically together as we would have done in the past. Nevertheless, research has been critical in tackling the COVID-19 pandemic and in delivering both novel therapies and vaccines, which have saved many lives here in Wales, the UK, and of course worldwide. And you have demonstrated the strength of our research base through the rapid delivery of platform trials like Recovery, and our leading contribution to the global vaccine effort, which is our lifeline back to normality, and been really pleased to see the impact that has had for the Welsh population, as well, of course, as across the whole of the UK. In Wales, the research community and NHS organisations recruited almost 50,000 participants into 110 COVID-19 research studies under the leadership of Health and Care Research Wales, and this is simply a phenomenal achievement. The NHS in Wales, along with all its partners, have consistently shown the ability to do things at scale and pace in delivering what was needed, and you have shown true professionalism, dedication and creativity. And I think that Wales raised its game in delivering COVID-19 research, and I think we can be hugely proud of our contribution. As we look forward, the evidence base that research provides has never been so important to drive the change we need to see in the emerging innovative health and change practices and new ways of working that have been introduced during the pandemic. And it's evident that you all share a common goal, that is to ensure the value of research continues to be visible and is embedded within our NHS and our wider systems to help future-proof our health and care services now, but also for future generations. Despite this significant research effort, there's been an inevitable negative impact on non-COVID-19 research. And at the start of the pandemic, the NHS across the UK suspended many routine clinical services, and alongside other UK research networks, Wales needed to pause the setup of new or ongoing studies that were deprioritised over focusing on COVID-19 studies. The impact of the pandemic on our social care service has also been extremely challenging. However, I know many of you have all been working tirelessly as part of a UK-wide managed recovery process to restart the research portfolio in Wales, and I wanted to recognise that I see that real progress is being made. The pandemic has been and continues to be a true test of our health and care system, and it's evident that through the foundations laid by A Healthier Wales, which is our long-term plan for integrated health and care, that we have created an environment in which our partners and workforce have actively embraced research and delivered transformation and innovation at pace, often in the most challenging of circumstances. The original vision for A Healthier Wales has been validated and remains relevant for the Wales of today and tomorrow, and our response to COVID-19, in my view, has accelerated the implementation of our long-term plan in some areas, and we have recently refreshed our transformation programme actions to ensure that we are focusing on those issues which have really been brought to the forefront during the pandemic. Whilst the pandemic created new and urgent needs for research and stimulated a huge response from the research community in Wales, internationally and in the UK, it's become increasingly clear that we will be living with this pandemic and its consequences for health and care in Wales for some time to come. And we therefore need research to help us to understand the impact of the pandemic now, into the medium term and into the longer term on health and care and onto the well-being of the population of Wales. And I hope that we can use that research, given our experiences during the pandemic, to inform decisions by policymakers, leaders in Welsh Government, the NHS in Wales, and the wider social care system across Wales also. As an example, the COVID-19 Evidence Centre, established earlier this year and funded, as you will know, by Health and Care Research Wales, is supporting us across Welsh Government and the health and care system to meet current and future needs arising from the pandemic. And this is testament to the importance and the realisation that research matters now, today and every day. And as we reflect, recover and learn, I see the research agenda will be key across 3 areas. So first, we need to continue to use research and evidence to support us in managing the pandemic through looking at the epidemiology of the disease, the validity and reliability of systems for monitoring its spread, service demands, the effectiveness of non-pharmaceutical measures for prevention, and a host of wider questions about the health pandemic effects of wider societal and economic issues. Second, we need to look at the impact of the pandemic on the health of communities and people in Wales. Issues such as the longer term effects of post-COVID infection and hospitalisation, the mental health consequences of social distancing and isolation, as well as the consequences of delays in seeking health and care access to services, and the health effects of the economic disruption caused by the pandemic. And thirdly, we need to capitalise on the impact of the pandemic on the health and care delivery systems in Wales. Of course, I oversee those in my day-to-day role as NHS Wales Chief Executive, and whilst we are changing a lot around our services, we do need to make sure that there is a lot more change and transformation ahead of us. And we know that the pandemic has led to the rapid and widespread adoption of a wide range of innovations in service delivery, including triage models, telephone and video consultations, and we need to understand through research what has worked and what has not. So I think that the research community has an important role to help us address the research priorities and allow the evidence base to evolve so that findings can be adopted into policy and practice and make a real difference. All parts of our healthcare system have played a significant role in the pandemic response. We've been reminded of the importance of collaboration and cooperation and how we are able to achieve greater impact as a result of aligning our focus, our priorities, our activities, and through pooling our collective knowledge to respond to these new challenges. And through partnership working, the efforts of our NHS professionals, our researchers, regulators, medical charities and industry have helped the UK to lead the world in COVID-19 research. The pandemic has led to opportunities to improve the way in which we work with greater use of technology and stronger collaboration. And we cannot afford to lose these benefits as we begin to focus on how we recover our services. But even before the pandemic, we have seen a growing body of evidence demonstrating that research active organisations provide better care and have better patient outcomes than those NHS organisations that conduct less research. So based on this, we need to ensure that all our services can offer evidence-based improved treatment and care options for patients, and that research is closely aligned with clinical care pathways to find new and better ways of delivering health and social care outcomes. And I think that Wales can provide world-class opportunities for research, and we now need to build on that offer by embedding health and care research into our culture and our systems, working in partnership with our communities, families and carers. These partnerships and collaborations, which have enabled our success during the pandemic, will remain vital as we recover from it. So just before I lead us into the next part of the session, I just wanted to say that the scale of transformation that I've personally witnessed over the past 18 months and the pace at which research has been delivered has provided a real-time demonstration of what is possible in the most challenging of circumstances. And it's important that we don't lose the impact of the progress that we've made. We need to continue to punch well above our weight so that Wales is seen to be research rich in both our offering and in terms of its impact. But the future can't simply be a return to business as usual. We must continue to embrace new approaches working across all sectors.
Just before the pandemic struck, I gave the James Mackenzie Lecture at the Royal College of GP's annual general meeting, and my theme was that we were investing in an array of parallel service which risked undermining the core reason for existence of primary care. And I finished by saying this: so we face a choice. We provide a range of fragmented services in order to ensure the fastest possible access and the greatest possible consumer choice, but only to people who've got the wherewithal to exercise choice. And I think the end result will be fewer GPs, paradoxically longer waits for care, much higher costs, and an inevitable drift towards patients seeking primary care from emergency departments. And most importantly, there could be better care for those with the fewest health needs and worse care for those who need it. That's all a bit dire, but I think many of these predictions are coming true and much faster than I expected. There are rapid reductions in the number of people who see their preferred doctor, complaints from some groups of patients they can't see a GP, GPs complaining they're overwhelmed, and emergency departments complaining that they're swamped by people who should have seen a GP. And my conclusion in my Mackenzie lecture was that to reverse that situation, we have to understand the design principles that make primary care effective. How does it achieve what it achieves? And to do that, we need to ensure that we promote, support, develop and invest in comprehensive primary care, not by accepting a gradual decline by hanging on to outdated ideas, but embracing innovation. But innovation is designed to support foundational primary care principles of accessibility, generalism, personal care and coordination of care for a defined population. That's how I think we build back better. Thank you for listening.
Thank you, and grateful if Helen could take on the mantle. Thank you very much.
Thank you, Chris, and thank you, Andrew. I'm going to give a talk now about my personal view of the role of research during difficult times, such as the times we've just been through and are still in to some extent. And I'm going to use an example of a research project that we're currently undertaking to illustrate that. Next slide, please. So during uncertain times, how do we ensure research plays its part? And if we cast our minds back to last year, it was a terrific shock to everybody when the pandemic began. There were enormous changes in clinical need, in patterns and volume of demand. And there was a real, almost a halting in usual care, provision of usual care, especially elective care, and also in active research. At the same time, there was a lack of evidence to underpin the provision of care in new circumstances for new as well as existing healthcare needs. We were a bit, in the research world, I think like everybody else, we were a little bit in shock as to what do we do now? How do we play our role? There was a scramble for COVID-19 related research funding for those that were interested in or able to undertake that type of funding. And there were some expedited research permissions processes in place, particularly to allow timely production of evidence for vaccines. I'm going to talk through now an example of some research that was funded through the Urgent Public Health Rolling Call from 2020, and this is called the TRIM study. And I'm going to talk really about lessons learned and then looking forward. Next slide, please. Thanks. So this study, the TRIM study, is about what triage model is safest and most effective for the management of 999 callers with suspected COVID-19. And it's a linked outcome study. The team members are listed there. Thank you. I'm speaking on behalf of all those authors. Thanks. Next slide, please. So collaboration, of course, is essential, and we had new challenges in collaboration because we were not sitting in the office. We could not speak to one another. We had to do everything remotely, and we were in all of the rest of the scrambling. We were trying to get our heads around Zoom and Skype and Teams and all of the ways in which we had now to communicate with one another. We pulled together a research team led from Swansea University Medical School, but with collaborators from a number of universities, ambulance services and other NHS providers and public contributors. And the study was funded by the MRC through the UKRI COVID-19 Rapid Response Rolling Call. It was funded from July 2020 to June 2021 for £360,000. Next slide, please. So if we, as I say, cast our minds back, and when I was preparing these slides, it gave me goosebumps, actually, casting my mind back and pulling out these images of ambulances queuing. It was really very intense times. The COVID-19 pandemic caused a surge in 999 calls. In some areas, people were saying it's like New Year's Eve every day. Ambulance services cannot and should not attend and convey all patients suspected to have COVID-19. So they had a real problem about who should they attend, and who should they convey. They were literally having triple the number and more of calls. So if they under-triaged and did not attend or send a patient to someone that needed an ambulance or needed to go to hospital, then of course there's potential for harm, including being left at home and being seriously ill or dying. On the other hand, if they over-triage and send resources to people that didn't really need them, then that's an overuse of resources, there's increased waiting times, and also people are at risk of hospital-acquired infections. So triage is absolutely key to this, sorting out patients for who should receive what response and who should receive an ambulance, who should have face-to-face assessment, who should be taken to hospital. This was in the context of a lot of uncertainty about the disease, about its risks, about transmission routes, and also many 999 staff in the call centre and ambulance frontline vehicles were sick or isolating. So quite a crisis. Next slide, please. So we put our aims together, which were we were very aware that ambulance services were thrown into this situation and didn't have the tools to triage for the types of symptoms they were seeing. We came up with these research aims for this study, which was funded, to evaluate the different models that were being used to triage and manage emergency ambulance service care for patients with suspected COVID-19 in England, Wales and Scotland. And the first part of the study was to describe those models and to understand call volume. And the second part was is to understand which models work best to get the right patients to the right care, using linked outcomes and also stakeholder interviews. Next slide, please. So phase one we've completed, and I'll talk mainly about today. And this was a survey of UK ambulance services. There are actually 13 ambulance services across the UK, and we emailed our questionnaire to chief executives, copied to research leads, and followed up by email and telephone. And the questionnaire covered two aspects. How were ambulance services triaging their calls during February to August last year to identify and allocate responses to those calls coded as suspected COVID-19? And secondly, we asked for them for data related to the 999 calls received during that period, those that were coded with suspected COVID-19, and also the pre-hospital outcomes. So which ones, how many were attended and how many were conveyed to hospital. Next slide, please. So we received responses from 12 of the 13 ambulance services after a bit of badgering. So that was really helpful, because of course they were all under such pressure. The last thing they wanted to do was complete a survey for us, but they could also see that it was important to do this work. So those 12 ambulance services, there are two main initial triage software systems in place. One is called AMPDS, the other is called NHS Pathways, and these were what was used in all those services for the initial triage. And then services made their own modifications to nationally agreed protocols. So in some cases, they upgraded their responses to calls. For instance, one service upgraded responses to calls with ineffective, where the patient was described as having ineffective breathing and myocardial infarction patients. And also other ambulance services added various questions about travel or symptoms, but there was some variation around the country in these, or around the countries, in how these questions were added. Generally, calls were further triaged within the call centre, but by a variety of different clinical staff: paramedics, nurses, advanced paramedics, GPs, other medically trained staff. And this was sometimes in the call centre through a clinical hub, a specific desk physically located within the call centre, or sometimes it was with links with other partners such as NHS 111 or NHS 24. And then various tools were used for triaging less acute cases, including the Manchester Triage system and the other ones listed here. Next slide, please. And then we were asking about what happened on scene and what was the triage that was happening by usually paramedics on scene. And again, services reported a range of protocols to support decision-making on scene, including the ones listed: News 2, the Manchester Triage system again, the JR Calc app, and generally senior clinical advice was available remotely to support decision-making from within the ambulance service, or sometimes through external arrangements, 111 or another service called Consultant Connect. So there were various arrangements in place, various tools being used. Next slide, please. So the next part of the questionnaire was about asking for data. And this slide shows you all emergency calls, not just COVID-19, but all emergency calls by service and then by the week of the study. And this was from February till, I think that's May 2020. So through the beginning period of the pandemic. And you can see that services, there's some sort of pattern here, which we know, which we are familiar with, because it's the pattern of the pandemic spreading. But there's a big variation in when services hit their peaks and troughs. But this is all 999 calls. I think the next slide is just COVID-19. Could we have the next slide, please? So this is calls identified as COVID-19. So you can see an enormous peak. And which is variable. That's not a total, the top one, that is one ambulance service. So there was quite a range of variation between services over the period that we looked at. If we could have the next slide, please. There's too much information on this slide, I realise, for everyone to look at, but the services are listed in the first column, and here you've got all the 999 calls during our study period. And the percentage that were coded as suspected COVID-19, you can see that varies from 4% to 20%, 26% at the bottom. And then the percentage of those, so that varies in itself between services regionally. But then if you look at the next column, you can see the proportion of those calls, the suspected COVID-19 calls that were attended, varies enormously, from 100% and almost 100% in one or two services, right down to 59% in one service. So with no clinical rationale or reason for that that we know about, literally the rate of dispatching vehicles to patients varied by that degree. And then, well, how many patients went to hospital? Again, of the suspected COVID-19 patients, this varied from just over 30% through to 54%. Not quite as wide a range, but still enormous variation. So this means that the care that you're getting is varying by where you live, based on which ambulance service you make your call to. Next slide, please. So I'm going to summarise those key findings on call volume. Call volume itself varied widely between services, and at the peak across the UK, it was 13% above the baseline, but that varied by service. And actually, all services ended the period with lower call volume than they started. That's all calls. But the suspected COVID-19 calls overall were 13% of calls, but this was between 4 and 26%. And even within services, the variation was wide. But Ambulance Service 12, at its peak, nearly half of their calls were related to suspected COVID-19 patients, which is mind-boggling, really, if you're thinking about trying to provide a service. Whereas in Ambulance Service 4, it was 11% at its highest. So the ambulance services were not all facing the same problem, and certainly not at the same time. There were two effects going on: a sharp rise and then a gradual fall in suspected COVID-19 calls, and a rise and then fall in total emergency calls. But these trends peaked and troughed at different times. So a very complex situation that ambulance services were facing. Next slide, please. In terms of the pre-hospital triage outcomes, again, variation is the whole message here. The proportion of calls to which a vehicle was dispatched for face-to-face assessment varied between 60% and 100%, and we couldn't see any relationship between that and call volume. And the proportion of patients conveyed to the emergency department again varied between 32 and 54%. And actually the lowest rates of conveyance were seen in the 2 ambulance services that had the lowest volume of calls coded as suspected COVID-19. So it was really hard to actually interpret these findings. Next slide, please. So in terms of the study progress, we've published our phase 1 results and we're moving into phase 2. In fact, we've had all the permissions and we've had to have a study extension because that's taken far longer than we hoped. But now we're waiting for the data sets to analyse, to answer those key questions about, well, which systems, what models work best for patients. Next slide, please. So I think this is my final slide. Now we're in a new era in recovery, hopefully, and there's still patients with COVID-19 being many, and ambulance services and emergency departments are under terrific pressure. And there are also patients with the normal workload and the normal caseload. Triage is absolutely crucial for care of patients with COVID and other health emergencies. And research has to play a role in informing policy and practice by understanding clinical and social needs, provision of care during COVID-19, and what worked well and what didn't. My final point is, in order to provide timely evidence, we do need to be slicker across the research process, and particularly in securing permissions to undertake this work. Thank you very much.
Diolch, Helen. Thank you very much. So, a chance for us to just draw together, some reflections, and there are some questions that colleagues have given you, which I'll come in a moment. But I just wanted to call out a couple of things. I mean, firstly, Helen, your last point on ensuring that the NHS organisations run towards the research ask, that's something that we do need to, I think, represent, given our reliance on science and evidence through the last 20 months. And certainly in the Welsh context, I'll have a conversation with chief executives to make sure that you do have that access, because this helps us to alter our services with the patients who are in front of us. And in your presentation, I feel both of you have given, for me, really practical insight, certainly in experiences that I've had to live through here. But it's really important to keep reminding ourselves of the context at the outset of the pandemic and the way in which we all, with our different responsibilities, had to step up with a lack of knowledge, watching kind of global events unfolding before us and leading to a response. But in a very salutary way, you've reminded us on the triage approach, of course, that getting that wrong either way can remain a question of life and death. So the strength of the evidence of the research is one thing, but the practical application does have kind of consequences, and I was really struck by that as you were speaking. And also, Chris, just on your own reflections, I think that reminder of what primary care activity is restored to now, in terms of the activity levels, and they are higher than we were even seeing before the pandemic. I think it was right that you drew in. It was almost like the media were doing a drum roll for your presentation this afternoon about the kind of primary care context, because of course it's the story of today, the story of the last few days about that kind of focus on primary care as well. But I think that you really gave a strong impression of the impact of the technology on the one hand, but I think it was right that you also highlighted about the need to recognise still there's an individual need and a context for individual patients. And there is a danger sometimes that we see these things as the answer to everyone given their circumstance. And I thought you gave a really personal perspective that this is part of the toolkit and a pretty fundamental one, but there are still other choices for the system to make. So thank you for those, just to pick up some reflections. So we'll come to a couple of questions for you, and I'll draw out a couple of general ones, but maybe if I could just start on the remote consultations, and what Chris, question that's come in, to what extent do remote consultations result in a subsequent need to follow up and consult? And if so, it might be making work, because people will come back into the system rather than saving time. So is it just sort of deferring the inevitable, I guess, is one of the questions there. And maybe if you could just draw into that again. The second one is, do you think that we leave remote consultations as something that is at the discretion of local practices, or something that just should be made to happen nationally, if I paraphrase the question as well? So just be interested in your reflections on those two. Thank you.
mean, the first point about whether it saves work or generates work, that was the basis of the paper that we did of a modelling study, and we did a systematic review of all the previous studies of this. And at that time, the conclusion of our modelling was that it probably increased work because quite a high percentage of remote consultations led to follow-on consultations. And there's a kind of equation between how long is the consultation, how many leads to another consultation, and is there an increase in demand. But critics of my paper since then have said, actually, we've learned to be better at remote consulting now, and that a much higher percentage can be managed remotely than previous research had suggested. And if that's true, it could save work. But then the question back to that is, but is it the same kind of work that you're doing? You know, you might be able to do it, but are you doing it as well? And I think that's the next question for research. And I think that you can do some things, but you may not necessarily do everything as well. So, you know, there's a fine balance. And the key point is not to assume that triage saves work. It all depends is the answer to that. It can equally increase work. On the question of whether it should be national policy or local, I would be very wary of any national, well, for instance, if I can be political for a minute, today's announcement telling GPs when they must see people face-to-face or remotely. I don't think it's right that politicians should tell individual clinicians what the right thing to do is on that kind of question. But I do think it's right that they set some general kind of policy expectations. And there's a wide variety in the way that practices in England are behaving at the moment. And I think sending a sort of message about, in my view, that patients should have some choice, and that if they feel their sensible thing is to have a face-to-face consultation, they should be able to get that. I think that, you know, that's the policy direction should be set, but the detail shouldn't be.
Okay, thank you very much. Yeah, I mean, I obviously was involved in the decision in Wales where, you know, I would suggest an exercise to create a national platform to allow for remote consultations that probably would have taken us about 7 to 8 years of negotiation and local innovation and practice. We rolled out in 4 weeks, basically. But I think the principle of it for me is to respect, you know, the individual patient need, but we do have a responsibility to at least enable that choice can be made. And I think that's probably the focus on making sure that these, you know, platforms can be utilised in that way rather than getting into the nuances of an individual contact. But that's a good question that someone's asked, because it's one that I ask myself often on this, because, you know, we can step in nationally, but I think sometimes that can over suppress some of the local opportunity and the local ownership of these issues as well. If I could just pull out a general question for the two of you, perhaps Helen, you could start with this one. You know, we all know that decision making and bureaucracy has sort of disappeared within the COVID pandemic. There's a pace and urgency around what we needed to do. So the red tape has been cut. But how can research help with maintaining safety in that context? Because, you know, perhaps the tape was there for a reason. So just be interested in your take first, Helen, and then Chris. Thank you.
So my take on this is that research bureaucracy could be cut an awful lot more. And although there, in some instances, yes, a research bureaucracy was cut enormously to enable trials, particularly of vaccines. It was only, I think, a small proportion of cases that flew through that system. And even though we're doing COVID-19 research, it hasn't been badged as urgent in that way, and we've still had to go through the normal processes. So, for instance, the TRIM study, we've only just managed to get the data now. It was stuck and stuck and stuck and stuck for a long time through those bureaucratic processes of really around data sharing agreements between hospitals and ambulance services and NHS Digital. And this, I don't think, is necessary. It's a lot of people not quite sure what they're supposed to be doing, a lot of risk-averse practice in terms of information governance, as well as research bureaucracy. So I think we've got a lot of work to do to streamline our processes and ensure that we can produce research quickly so that it can inform policy and practice.
Yeah, and again, speaking on my practical role, don't know whether I'm meant to be intervening with these areas, but you know, I'm having to remind organisations that there are already existing concordats in place for data exchange, you know, to allow for the use of data quite properly for purposes across agencies as well as in the research context as well. So, I mean, sometimes we need to reaffirm that, but actually there's a lot of permission already in the system, and people sometimes try to reinvent the bureaucracy, I think, maybe for different interests and different reasons. Chris, do you have any reflections on that question? Thank you.
Firstly, to agree with both of what you've said strongly, and also just to emphasise that it's incredibly costly. Almost every project ends up starting late because of all these kind of problems, and then that means we have to apply to extensions to the funding bodies, which cost them loads of money. So, you know, I just think it's terribly wasteful, and particularly this issue of data sharing issues. You know, that's the biggest area where really major advances have been made because of being able to share data that has been held, and which can be done perfectly safely and responsibly. There's no reason why anonymous data can't be used to understand what's going on. And we've done that in some of the COVID studies, and I really hope some of the learning from that can be taken forward into the future.
Okay, thank you very much. Again, I'll go for a question that I'd be interested in either, well, both of your comments on it. So Chris, in your presentation, you were calling for more real-world rapid QI-like research. And just to ask both of you whether you think the current research ecosystem is set up to actually achieve that. Helen first, thank you.
Well, my take on this is that we need a range of research methods to answer different questions, and that, yes, the type of research Chris is talking about can really be helpful for rapid change and rapid evaluation and putting evidence in a timely way. However, when it comes to really having definitive evidence about whether a new drug or a new treatment works for patients, whether it's cost effective, really, I don't think you can beat the randomized control trial for that type of evidence. But it would be great if we could do them quicker. And then I come back to the same issues around sort of slowness in the system from start to finish and a lot of duplication in that system. I think we could be a lot slicker. COVID-19 did show that it can be done more slickly. So we need to learn those lessons. But yes, a range of methods depending on the question you're trying to answer.
Okay, thank you. And Chris, you made the pitch, so do you want to elaborate a bit more? Yeah. Thank you.
Firstly, I'm not against trials. In fact, a lot of my career has been doing trials, but I think what I've learned from them is that they're great for simple treatments like a drug or a vaccination, but they're not so great for complex service changes where there's a lot of local contextual adaptation, and whatever you're researching isn't quite the same once it hits the real world as what you had in mind. And one thing I've learned from COVID is how we've had often it's local things, really strong partnerships between our local CCG and our local universities, with us helping them to find data, to answer questions that they want to know the answers to, and to doing it really quickly. And I found that an incredibly positive experience working with our local data analysts in the CCG. And the research I quoted about the rapid shift in remote consulting, that came out of that kind of research where we were able to work with them collecting data, us analysing, us doing qualitative research with professionals about what had they learned about how to make these rapid changes and how we could share that best practice quickly with all the other practices around.
Okay, thank you very much. So both of you feel free to reflect on this, but I sense that it probably is more to do, Helen, with your presentation, and just as you were exploring the kind of triage information and the way in which the ambulance services were representing, but just a question about whether, I guess, either of the research, but maybe yours particularly, Helen, got into patient demand to just track whether there was an impact on particular conditions, you know, reducing activity or admissions like cardiac or stroke, and whether there is any experience that you picked up on during the pandemic that kind of shows what was happening in these extraordinary times. I'm sort of struck myself by reflections I had from respiratory physicians that whilst on the one hand they were dealing with the respiratory virus, of course, on the other hand, the admissions that would have come in, for example, due to, you know, associations with air pollution, for example, had really kind of dropped off in the normal way. So perhaps I could stimulate it in that way. Thank you. Helen?
So in a way, that's more relevant to another research project I'm doing, which is about the effectiveness of the public health policy of shielding, which is a terrifically complicated problem or policy to evaluate, because people were identified for shielding and sent a letter and contacted, but whether they shielded or not is another matter. That was a personal decision. And then other people who were not sent a letter may have shielded, and there was a lockdown on top of it. And in that, we are trying to track through routine outcomes of deaths, COVID infections and hospitalizations, but also self-reported outcomes of anxiety, depression, loneliness, adherence. So in that in that project, which is called EVIT, which is the French word for avoid, so it seems quite right. EVIT, we are looking at that really complex set of outcomes. And then you've got the issue of, if this outcome is better but that outcome is worse, how do you balance them all up? But again, my take on this is to provide that really strong evidence so that then policymakers can actually know what's happened and what's going on in order to inform policy in the future. In the TRIM study, we focused on people with COVID-19, either categorised in the ambulance service or then in hospital. We didn't look beyond that. It was completely focused on COVID.
Okay, thank you, Helen. Chris, just to pick up if you've got any reflections on that, whether it's research you're involved with or just a comment. Thank you.
Yeah, we have looked at changes in the nature of what goes on in primary care consultations, and there are some interesting things happening that we don't really fully understand yet. So big reductions we found in the number of people presenting with worrying symptoms, that the sort of things that might me refer them because of potential cancer. So there's been sort of criticism or concern about fewer people going to hospital. That's partly because fewer people are turning up at general practice with potential cancer symptoms, and not entirely sure why. And quite big increases in mental health problems. I mean, this is more anecdotal, but GPs tell me that they see a lot of people with lots of anxieties, and I think that's a consequence of social isolation that people have experienced over the last year and a half.
Yeah, I think it's really important to recognise that a particular area for ongoing research, has got to be that mental health, emotional health, of individuals, but probably more of our communities as well. I sort of sense that there's a lot more to come from all of us having lived through this, in our personal lives as well as our professional lives, and probably that's going to be something we're going to have to learn more from. I'm really struck by what you just said there, Chris, as well, because even on our own assessments, looking back over the last 18 months, particularly during the peaks, the first and second wave of patients that perhaps didn't come into the system, we probably feel that there are somewhere around over 4,000 cancer diagnoses that are still to be made out there in the system that we somehow need to sort of track back in, although at least cancer referrals are significantly coming back in our system, at a higher level than they were before the pandemic. Got a little bit of time, and I was just going to, no other questions that have formally come through to us at the moment, but I was just going to ask you, Helen, if you don't mind, whether as you go in as a researcher with your eyes open on what you're going to discover, were you actually surprised about any of the results, particularly about the sheer level of calls coming in for COVID? And the reason I say that is that I know that as we were going through our early response in Wales, hopefully they were one of the respondents for you, but around 1 in 10 of calls coming in were COVID related. Actually, even over the recent weeks with high community prevalence, we've seen that actually increase sometimes to up to 1 in 5. And the point I would make is that when the ambulance service is responding to a COVID related call in advance, they've got an 8-minute response time, but it takes them 6 to 8 minutes to simply put the PPE on as crews, and that's a lot of pressure for them to get to potentially what is a life-saving situation. So I just wondered if you were generally surprised with a research lens in, or just as a layperson.
Yeah, so I always try to go in with an open mind. I think I was surprised at the variation between the demand across the country and the proportion of demand that was COVID related by service. But that was affected by those two effects that I talked about. Both the overall 999 calls were going up and then down, and then COVID-19 calls went up and down, but not in the same way in different places. So these effects were quite hard to disentangle. Overall, I just really felt for the ambulance services and the crews who were responding to patients and queuing outside of hospitals, and a lot of their colleagues off sick. Just tremendous pressure, and I just personally feel a great deal of admiration for those crews in that context to be providing that service. So not really particularly surprising findings, apart from that degree of variation. Yes. And that, as a researcher, and I think Chris will probably agree, wherever you see variation, you want to look at it more closely, because if people are getting different care and different response just for where they're calling or where they're having their symptoms, there's something not quite right. So you want to understand that better.
Yeah, thank you. Look, and I just want to, reinforce the comments you made, about ambulance staff, and I would say our health and care staff more generally. I just think there's been extraordinary efforts over the last 20 months, driven by a commitment to do the right thing. And interestingly, on your variation point, I mean, I was obviously in my national role watching how the virus was actually spreading and tracking across Wales to different levels. So there was variation naturally, just because of the way that was, moving, whether it was from across the border or from area, or whether it was an urban or rural mix as well. So lots of different ways of looking at this as well. I was going to thank you both actually for your time this afternoon and for joining us again, for presenting your views really clearly, and also being very open in your answers, and recognizing that sometimes in these virtual events we can miss a little bit of the reading of the room, I suggest. I mean, I'm really grateful for the reminder in your session for the importance and urgency of still ensuring that we're prepared to transform and change our services. I had the privilege in my national role of being part of the 70th anniversary celebrations of the NHS, and clearly I've had to see many fantastic efforts and responses in the most challenging of circumstances in the last 20 months in particular. But I think it's, whilst we hold dear the values and the principles of the NHS that was established in 1948, it's really important that we don't allow ourselves to be fixated on everything that was put in place in 1948. And I think that when we are working within our systems and looking at the research and the evidence and the practice around us, we've got to keep pointing forwards. So thank you both very much for just allowing us to advocate for that, because change, it means better care for our patients and for our populations. So thank you very much for this afternoon. Pleasure to see you both. Thank you.
Thank you.
That brings us to just a little shade past 4 o'clock, and I'm very grateful for Helen and Chris for their involvement. And you're tracking your agenda like me, and you'll know that this is now the awards side of the conference, just to allow us to land this next 10 to 15 minutes or so. So this now means that this is the time to find out if you are a Health and Care Research Wales 2021 award winner. And just to remind you that these awards celebrate the achievements of the research community in Wales over the past 12 months. And we have a brand new set of prize awards to give out this year, with 2 new categories, Rising Research Star and Impact, alongside our award for public involvement. And I wanted to just say thank you to all of you, those of you who entered the awards, and also, of course, to the judging panels for their time and contributions. Just to say that the winner of each category will receive a £250 bursary to attend a training course, a conference, a workshop or similar event to develop an area of their research skill set. But please feel free to share your congratulations with the winners in the chat box as we go along, and also on social media, as I said, to use the hashtag ResearchWales21 so that we can celebrate virtually together. So just to move on to our first award this afternoon, that is for public involvement. And this award recognises the very best use of public involvement in a health or social care research study using the UK standards for public involvement. And this category received another strong field of applications, with the judges remarking on the quality of all entries and the difference public involvement is making in research. And just to say, the winner is... This is my X Factor moment. Dementia and diversity, understanding diversity, implementing equality, creating shared learning. And just to comment on the winner, the judges all agreed the inclusivity of members of the public in this project was really exceptional, and not just with one underserved group, but across a wide spectrum covering ethnicity, language and sexuality. The research team used many novel approaches to involve the public, including through art and engaging with playwrights. And the judges believe this to be a leading example of public involvement, which they hope can be embedded with other research programmes in the future. So congratulations to the Dementia and Diversity Research Project. And let's hear from Sophia, who is the researcher and public involvement lead for this project.
Hello. In the Dementia and Diversity Project, people with lived experiences of dementia care, as well as experiences of being in a minoritized group in relationship to ethnicity, language, sexuality or disability, contributed their experiences and their advice in reaching out to diverse and underrepresented communities, advising our research, our analysis, our public involvement strategy, as well as our dissemination. More specifically, they directly inputted in 3 performances where they were involved in script development on how do we best communicate the research findings. These performances are available on YouTube, and people were able to contribute privately in public through their own creativity, so that they were in the driving seat of everything that we did.
Okay, so thank you to Sophia, congratulations and well done, and really nice to hear that personal update as well. Just to comment on this particular category, there was also a highly commended, and the judges also wanted to highlight the Talking Trials project, which is exploring clinical trial perceptions amongst minority ethnic communities. And the judges felt the project's use of innovative ways to engage with different community members will open up new opportunities to involve members of the public in the future. So just wanted to call that one out, and well done and congratulations for that reference also. So moving to the next category is impact, and this award recognises the difference that Welsh health and social care research is making to people's everyday lives. And the judges were really encouraged to see the breadth of research taking place and the impact and influence the research will have on practice in Wales. And the winner is the OBS Cymru project, which is now standard practice in maternity care to reduce major bleeding after childbirth. This was a clear winner with the judging panel, demonstrating real health benefits to patients and also changing routine practice in Wales and the UK. So congratulations to the OBS Cymru team, and let's hear from the team's Dr Sarah Bell.
My name is Dr Sarah Bell. I'm a consultant obstetric anaesthetist working in the University Hospital of Wales in Cardiff, and I'm going to introduce to you the OBS Cymru project, which has reduced major bleeding after childbirth or postpartum hemorrhage. Over the past 10 years, a multi-professional postpartum hemorrhage research group led by Professors Collins and Collis has improved understanding of a patient's clotting changes during postpartum hemorrhage and the best ways to identify and treat this. The research findings were combined into a complex intervention called OBS Cymru, which adopted the approach into routine maternity care throughout Wales. The results were published this year and include reductions in progression to massive postpartum hemorrhage and blood transfusion, with 160 women per year now avoiding transfusion in Wales. The OBS Cymru approach is now routine practice in Wales, with themes integrated into NHS Scotland and England and likely to change future national and international postpartum hemorrhage guidelines.
So just to say thank you and llongyfarchiadau, congratulations to the OBS Cymru team. Also, just to call out a couple of other awards that were attracting the attention of the judges to be highly commended. So judges would also like to highlight the potential impact of 3 other research projects. So David Bosankay's Perceived Research Project is investigating decision making around major lower limb amputation, which has the potential to make a major difference to the lives of those affected. And the judges were also impressed with the potential of Mohammed Al-Amri's research exploring virtual reality and wearable technology for patients with arthritis, and they are particularly keen to see how that might be used by clinicians in the future. And thirdly, Prime Centre Wales shared decision making in rare disease research, which has changed NICE guidelines. And now just moving to the final award of the day, and that is for the Rising Research Star. And this award recognises those in the early stage of their health or social care research career who were already making an outstanding contribution to their field and or developing as emerging leaders of the future. And members of the judging panel were very impressed with all entrants in this category and have asked me to say that it was a really difficult decision, with everyone showing tremendous potential. And the winner is Emily Holmes. Emily is the Senior Research Fellow for the Centre of Health Economics and Medicines Evaluation at Bangor University. And the judges were impressed with Emily's application, describing her as an exceptionally strong candidate. Emily demonstrated great outputs and achievements in health economics research, including a range of published papers and a large number of successful grant awards. Emily is emerging as a leader in health economics, an area of research that's becoming increasingly relevant and one of significant importance for Wales to be leading on in the future, and one that I have a particular interest in myself. So llongyfarchiadau, congratulations, Emily, and let's hear from Emily.
Hi, I'm Emily Holmes. I'm a health economist at Bangor University, where I research people's preferences for healthcare. Following my PhD in medication adherence, I was awarded a Health Research Fellowship by Health and Care Research Wales. I'm investigating how people's views and behaviours impact the use of antibiotics. I have a track history of research excellence, having achieved over 30 peer-reviewed publications and over £1 million of grant capture, of which I'm proud that over half has been achieved as principal investigator. I've contributed evidence to the European Medicines Agency and been involved in the assessment of new medicines in Wales. I'm committed to generating new evidence on how people's behaviour and choices impacts the value of services delivered by the NHS. And I'm also committed to my ambition to become a professor in health economics, leading a research centre in preference solicitation and building research capacity in Wales.
We also have some highly commended references from the judging panel, and the judges would also like to highlight the strength of applications from Rhiannon Owen and Victoria Shepherd, as well as the passion for specialist research into autism and maternal wellbeing that shone through in Amy Grant's application, and well done to all of you as well. So that brings us to the end of our award presentations. Always seems strange doing these things when we're not doing them amongst company rather than virtually, but thank you again to all of those who entered. It was good to see a large number of entries this year, and thank you also to the awards organisers, the judging panels who've given up their time, and of course congratulations llongyfarchiadau to our winners. So it just really leaves me, in having joined you at the end of this afternoon, to take the opportunity to close today's 7th Health and Care Research Wales conference, and would really like to say thank you to all of you for attending here today. I know you've done so in the middle of lots of other responsibilities and activities, and I'm grateful that I've been able to spend a bit of time with you. I mean, so many of you have attended, which is a real testament to your dedication and commitment in driving forward the research agenda here in Wales, and I do hope that you've all enjoyed your day. I just wanted to pass on my thanks on all of our behalves to Paula Hughes and to Kate Myers and the Health and Care Research Wales communications team for delivering, I hope you would agree, another successful conference. And as we all know, in preparing for these events, you should never underestimate the level of planning and work that has to go into preparing an event of this scale. And as we move forward, we need to continue to embrace all that research offers to ensure all our health and care services offer evidence-based treatments and care options for the people of Wales. We've seen much change over the last 18 months. The pandemic has changed the way in which health and care services have been delivered, and of course changed the way in which we work and interact. But our common goal remains to improve the health and care of the people of Wales, and that will remain at the heart of what I know you do and we do as a research community. And I just wanted to say thank you and commend you all for your dedication and commitment to the research that is happening. So we look forward to seeing you all again in 2022. Thank you and goodbye. Diolch yn fawr iawn a hwyl fawr.